Hello, I am Isabel Olivera, a medical writer for the European Hematology Association, EHA. I have the pleasure to have here with me today Miriam Santos Freire and Loris Brunetta. Welcome to both of you and thank you for being with us today. Can you please introduce yourselves? Please, Miriam first.
Hello, so I am Miriam. I have sickle cell, SS. I am Portuguese and British. I was born in Angola. I lived in Portugal for about 40 years, and for the past 10 years, I have been living in UK, lately in Cambridge, where I learned about patient advocacy, and I have been developing my role with two hats. A white sickle cell patient living in the UK outside of London or Birmingham, where everything happens, and the Portuguese patient representative worldwide, part of the board of the Portuguese Hemoglobinopathies Association, APPDH, and representing Portugal within the EuroBloodNet, the European Sickle Cell Federation, the European Hematology Association Patient Advocacy Committee, and the Red Cell Network in the UK. I am a full-time language consultant, married, no children.
Thank you very much. Can you please introduce yourself, Loris?
Yeah, of course. Thank you. Thank you for this invitation. I'm Loris Brunetta. I'm based in Italy, in Genova, in particular, and I'm a patient with thalassemia, with beta-thalassemia major. I'm 61, so I went through all the story of the disease, because when I was born, thalassemia was a fatal disease still, and my prognosis when I was born and diagnosed when I was 3.5 years old was still the adolescence. And now I'm 61, and many other patients across maybe in the Western countries are older than me. So this means that we can survive with this disease and deal with this disease in a better way. I'm based in Italy. I'm a patient advocate since more than 40 years now, because I established a local association here in Italy when we started to work for the patient advocacy, but also I'm a founding member of the Thalassemia International Federation back in 1986, and a lot of other activities. I'm, as Miriam as well, a patient in the patient advocacy committee of the EHA, in the governance of EuroBloodNet, the European Reference Network for Hematological Disorders, and in many other organizations for rare diseases, in particular for developing policies for rare diseases, and also just for educating the patients to claim for their rights.
So thank you very much to both of you for agreeing to be our guest today. We're going to be discussing what are patients thinking about gene editing. So you are both patients yourselves from sickle cell disease and thalassemia, but you are also in contact with other patients through this all your engagements in patient advocacy groups. So my first question is really basic, is what is it like today to live with these two diseases? What does it involve as everyday burden? What do you have to do often? What is it like to live with this? So can you please explain, Miriam, first?
So sickle cell is the how can we say? Well, it's a red blood cell disorder, a non-malignant red blood cell disorder. And individuals affected by sickle cell carry the sickle hemoglobin S gene mutation on at least one beta globin gene. And this is important for the gene therapy, because this is the one that is the key to solve the mystery. And normally healthy red blood cells are round and biconcave in shape. They move around the body carrying oxygen, but in sickle cell, The red blood cells resemble the shape of a farming tool known as the sickle, so like a C, right? Well, it can have various shapes, but usually we call it like that. So it's not a round one, it has spikes and things. And so with less oxygen, the blood becomes more thick and they tend to clog, especially in the joints. And that causes the main thing is severe pain, but also acute chest syndrome, organ damage, and many other things, reducing life expectancy. So day-to-day usually is with fatigue, a lot of fatigue, because hemoglobin levels are lower, much lower than usual. And then it's the pain is a day-to-day companion. For it varies depending on the patients. It varies if it's chronic pain or if it has to do with the crisis. Usually adolescence and infancy is more complicated in terms of hospital admission. So it's really disabilitating. We miss school a lot. We suffer a lot from differences in temperature, dehydration. That's the day-to-day. Until now, there are no curative treatments. The only one is the bone marrow transplant, which is only for a few, unfortunately, and it involves chemotherapy, and the gene therapy will be another one as well. And unfortunately, for about 30 years, we didn't have any new drugs. There is only hydroxyurea, which is not valid for everyone. Not everyone is eligible for it. And many patients also go through regular blood transfusions with a lot of risks because the veins are not good and the complications with iron chelation and a lot of different things. But the two drugs that came out recently, voxelotor and crizanlizumab, after not a long time in the market, they were withdrawn because there was no evidence that the benefits would outweigh the risks. And so that's the journey for now. Complicated one.
Thank you. And what is your experience, Loris?
Thalassemias, because it's not only one disease, but it's a group of diseases, has different outcomes according to the severity of the genotype and the clinical phenotype of the disease. So this means that there are situations where so-called non-transfusion dependent thalassemia that can have better outcomes, even though they occasionally can have blood transfusion, red blood cell packed in blood transfusion, but in a low amount during the year. People with thalassemia intermediate, it is what we call today non-transfusion dependent thalassemia, that in a very close to the threshold to the thalassemia major, and they require to be transfused regularly. And of course, the thalassemia major patient like me, we must be transfused regularly every 3 weeks. And so this meant in terms of quality of life, because the main issue is always for us and for the people affected by sickle cell is the quality of life. We in the Western world are very lucky because we had an excellent, good standard of care developed across the years, and also the possibility to access very easily to the standard of care and also to the drugs that are on the market for targeting the complication, etc. But thinking about thalassemia, and as a board member of the Thalassemia International Federation, TIF has published a review in 2023, and they make an investigation across the world among the patients with thalassemia. Only less than 7% in the world can have access to the optimal care. The other people are still struggling to survive with this disease. The treatment consists in blood transfusions, regular, for thalassemia, for the most severe genotype, the thalassemia major, beta-0, beta-0 in its genotype, means to be transfused regularly every 2-4 weeks with 2-3 blood units of red blood cell packed, and to have a multidisciplinary care, to have the availability of iron chelating agents, because accumulating the iron transfused with the blood transfusions accumulate in the organs like the liver, the heart, and provoke a lot of damages and malfunctioning of these organs. So we need to be chelated from all this iron. Also, multidisciplinary care means that we can suffer occasionally from many other complications, primary and secondary, of thalassemia, like osteoporosis, endocrine problems, and many other situations that should be monitored and tackled timely in order to avoid the development of worsened situations that can, of course, impact on the quality of life and also on the lifespan.
So to summarize, what a patient that needs transfusion at the moment, because not all of them are transfusion dependent, as you said, needs to be transfused. A patient will need to be transfused every 3 weeks, more or less. This is a huge burden. You will have excess iron accumulating, so you need chelation. So this will be the normal burden of severe patients, severe thalassemia patients, and sickle cell disease too.
Many sickle cell patients also go through it. What I know is the cycles are usually it's slightly different. Although there are patients who accumulate sickle cell and thalassemia, so the scenarios can change. But many patients go through are transfusion dependent, and they go on every 6 weeks or every 8 weeks. It's not exactly the same because the disease is not the same on every patient, and even in the same patient, which is one of the difficulties, crises are not always the same. There are many different factors. People always like a little bit of numbers to put things into perspective. There is a real effort to work on national registries to put numbers and to know, because currently it's considered the largest genetic disease, largest growing genetic disease, sickle cell. It is said that worldwide, 8 million people are estimated to have sickle cell disease. It's an inherited disorder, right? Most of those are in the United States. Most of those in the United States and in the UK are of Black origin, so African and Caribbean. But worldwide, the reality is not exactly like that. So it's predominantly a disease coming from Africa and Caribbean, yes, but there is also coming from Middle East, the Mediterranean basin. It's mainly prevalent in low-income areas. And so that's exactly what Loris was saying. So access to standard care is difficult. Numbers are difficult to qualify it, and it's difficult to push for it and to advocate for it. But we are on the right track, and gene therapy will be, the difference is that until now we've been having treatments and medication to address the symptoms and to improve the quality of life. But with bone marrow transplant and gene therapies, we are really talking about a potential cure, and that will be key. Yeah.
This is what I was going to ask you now, because Casgevy has done a lot of noise, obviously. It's the first CRISPR-based gene therapy that has been approved worldwide. It's the first case of a CRISPR-based gene therapy. And so this really has the potential to cure the disease. Of course, because it's the first treatment, there are doubts about it also. And this is what we wanted to ask patients. How is this landing in the patient space? What are your thoughts about receiving gene therapy? Because potentially there is a cure, but obviously there are always drawbacks possible safety issues. And this is a life therapy. So once it's been given once and you have been treated with this gene therapy, you cannot go back. So how are patients thinking about this?
We have the expectations to be cured and not to have to deal no longer with the hospital, with needles, with blood transfusions and medicine, etc., etc. Of course, it's to become at this point, it has been a very long run for the scientists and also for the patients. We know that in the process there are challenges for the patients, and the patients should be aware of these challenges and should have the possibility to discuss, because it's not, sometimes we are hearing about speculation for finding the best candidate for this treatment. This cannot be an algorithm to decide who is the best candidate. Who is the best candidate? Only the patients can decide. Because this should be provided on a voluntary basis. Patients can ask, I have too much of the burden of thalassemia. I want to try the way of this new treatment. Knowing the risk for the future. We don't know. We have to wait, I think, quite a lot before being aware of all the complexities of these situations.
I think that the gene therapy, as it is right now, it still goes through chemotherapy the same way as the bone marrow transplant does. And I think that the intention with gene therapy as it evolves is to go to use the patient's own stem cells and deviate from all the secondary effects and the limitations of going through chemotherapy. So that's also another thing that let's hope that the future of gene therapy will carry as well. But it's the different scenarios between thalassemia and sickle cell. For sickle cell, we're still waiting.
Okay.
And just to give you numbers, and there is quite a list of what patients consider about not just gene therapy, but also gene therapy. I was reading yesterday that, for example, patients going on hydroxyurea, the cost would be approximately, I don't know, $1,000 per year, right? Patients going through voxelotor, crizanlizumab, it was estimated to go through, I think it was 100,000. And the cost associated to the gene therapy is something between 1.2 million and 4 point something, which is absolutely absurd and which puts it in a scale. What Loris was saying is very true about it. They must want it. And it is a long, long road going through either bone marrow or gene therapy. I was reading a couple of cases yesterday. It's about 1 year with long hospital admissions. It's a really long thing. So I had no idea, and it's really worthwhile knowing what it entails.
We are waiting for the negotiation at national level for having access to gene therapy. It's fundamental for every patient community to have the possibility to access this gene therapy. As I told before, it's should be a mutual decision to discuss among the scientists, the treating physician, the patients, the families, because I think this is meant for the children rather than for adults, despite the, of course, because treating a children, you can justify the cost because you can cure the disease at the very beginning. There are adults in severe condition, really severe condition, that need to be treated as well. So the most important thing is to have the possibility to access to this treatment. And then it's a choice. I think it's important to speak about the need for both the disease, in this case, blood requirements. The aim of gene therapy is improving the hemoglobin level. Sickle cell disease, it's not only improving the hemoglobin level, because there are many other implications, particularly in adult patients, because they have all the consequences of many years with the disease. It's important to improve the standard of care. My major concern, and it's the same for thalassemia. If I have an infection in the liver, gene therapy for thalassemia cannot treat also the infection I have in the liver. I have patients with thalassemia that underwent the liver transplant due to the infections. So for this reason, I thought it's important for children mainly than for adults. But
just one thing about that is that what has been approved is for patients over 12 or from 12 years onwards with a history of severe pain crisis, which are not eligible for other types of treatments. So you need to be, there is a quotation from someone in the US, you have to be sick, but not too sick. And it's exactly what Loris is saying. So you need to have a severe overall condition, but they take into consideration how far you are with the organ damage and everything.
If you can both give us a takeaway message from your perspective and the patient organizations you are involved in, what would be a takeaway message for the perspective of this gene therapy for the patients that are listening?
My take-home message is very simple, I think. Of course, as told before, this gene therapy, this innovative treatments, this potentially curative, one-time curative it's excellent for the patients that live for a long time with such a disease, impacting disease on the quality of life. So the message is very easy. Of course, we need to push this way in order to find better solution for the challenges we have to face. We need for the patients to have a good standard of care, safe blood for blood transfusion, accessibility to iron chelating agents, multidisciplinary care. This is a paramount for all the patients with these diseases, I think. Much more than the gene therapy.
So do not forget all the others, which are the majority, that cannot go through gene therapy, at least at the moment. So improve gene therapy, but also do not forget to improve all the other treatments.
Exactly.
Okay. And for you, Miriam, what would be the takeaway message?
I will not repeat what Loris said, although I fully agree, and I would say exactly the same. I will also underline another aspect, which is the importance of enrolling in the registries to have the numbers, the real numbers of how many patients we have with sickle cell anemia and with just the trait, because it is important, especially in the transmission of the disease, as it is a genetic disorder, right? Also, the importance of research and of patient participation in research. So it is important to know what is happening out there and to collaborate. And patients many times say, oh, there's nothing happening. There is a lot of stuff happening in the background. Only in some countries like the UK or France or the US or some countries have portals where patients can go and access and see what's going there and have access and can enroll directly in the clinical research. Smaller countries have a lot more difficult access even to the information, to the possibility of participation in the clinical trials and everything, and medication comes along later on a later stage, okay? But it is important not to lose faith and to participate. And the role of patient associations is really important because they establish the bridge between the research and also the healthcare providers and the patients. They can help in the sharing the information, making the information available, making information more accessible, because the clinical trial information is very technical. It's very difficult for the patient to understand, and patients are entitled to having the information, but the patient association are really, really key to establishing that bridge, to advocating for the patient interests and needs. So there is one really good thing. We all lack participants, and patients really usually shy away from having an active role and speaking up. We need to speak up because no one will come to stand up for us, right? So it's both on and for healthcare professionals and industry to listen to the patients and have their interests in mind as well. It's not just numbers. People are there, and it is important to keep them informed and to make information easily accessible and understandable.
So that was also very clear. So to get involved for the patients, both register obviously, but get involved, and for obviously the clinicians and researchers to pay attention to you. Thank you very much to both of you for your time, for this fascinating discussion, and for sharing your experience with us. And thank you to all of you for tuning in and listening.